As we begin our next session, a model approach to addiction medicine education, I'd now like to welcome to the podium Dr. Kevin Kunz, who serves as the Executive Vice President of the Addiction Medicine Foundation. Through Dr. Kunz's leadership, the Addiction Medicine Foundation has greatly helped advance the addiction medicine in medical schools through the establishment of addiction medicine fellowships. Dr. Kunz, I turn it over to you.
Good morning. Thank you, Director Anamoto, and thank you, Dr. Koob, Dr. Volkov, and Director Botticelli for your leadership in this field and for your effective advocacy in translating addiction science into practice. In 2009, as the campaign for addiction medicine fellowships began, the National Institute on Alcohol Abuse and Alcoholism and the National Institute of Drug Abuse gave the very first support grants for this endeavor, and they are still supporting this work. Their investment has also resulted in nearly $20 million of additional funds into the development of new sustainable fellowship programs, of which there are now 42. Dean David Stern and I will be facilitating this session. Medicine is now formally responding to the need for a workforce of qualified addiction medicine physicians. We will summarize 3 expected next steps: the further expansion of addiction medicine fellowships, the modern approach to building the physician workforce through educational change, and the emergence of centers of excellence in addiction medicine. I will start with an overview of the need and strategy for expanding addiction medicine fellowships. Oops. So this will wake up your basal ganglion. You've seen this before. This is the topic of the day, the drug of the decade, or the couple decades. And I am going to actually start by focusing on death. Death is a crude measure of health, yet death reflects the natural history of a disease. In the case of addiction, it is also reflective of the substantial secondary medical, public health, and social problems which addiction drives. These are the death rates from opioids by state. Is there anyone in this room from a state where opioids are not a problem of great significance today? Opioids. Whoops. Here are the combined death rates by state from opioids plus alcohol plus nicotine. How is your state doing? How are you, as a medical leader or educator, doing? There are states where 1 out of 3 deaths today are caused by alcohol, nicotine, and opiates. And as a nation, we have a poor record of addressing this. And it is not just a state crisis and a local crisis. It is a national crisis that involves all drug use. Here's another way of looking at this. There are 2.6 million deaths in the United States each year. 1% are attributable directly to opioid overdoses, 1 out of every 100 deaths in America. 3.5% are attributable to alcohol, 19% more to nicotine, and about 1% more from other illicit and licit drugs, including non-opioid prescriptions written by physicians. 1 of every 4 deaths in America today are attributable to these substances. What these numbers indicate is not the real story. The real story is that these deaths are very personal. Personal for parents, siblings, our children, our nieces and nephews, our friends, neighbors, colleagues, our children's friends. Personal for me, personal for you. Most of us and most of society have come to realize that addiction is not a statistical or purely scientific disease. It is a personal, painful, disruptive, life-changing disease for all around it. And that is why we are here today. We are here because we deeply care about our patients, families, and communities. We are here because we have compassion for those who are ill or in harm's way. As physicians, we have devoted our lives to the care of those who seek or who need care, who need our help. This is our work, and right now, for all of medicine, it is the most important work we can do. How can we do it? This slide illustrates how medicine when it shines its light on a problem, addresses that problem, and has results. What is the plan of attack? Within the medical world, we couldn't talk about this if we did not have recognition by the American Board of Preventive Medicine, the American Board of Medical Specialties, and the Accreditation Council for Graduate Medical Education, because that put us in the House of Medicine, and now we can be part of this. There's a continuum of competencies from medical school through fellowship training. We see that in every field, and I'll pick on cardiology as well. Clinical experts, faculty, and change agents coming from fellowships drive the science, the practice, the teaching, and the education through all of physician training. And now, well, so the fellowships become the epicenters for a successful response to whatever that problem may be. And we do need a successful and a new response to the addiction epidemic that America has had for decades upon decades. CME will never suffice. We are at a tipping point. Here are the 183 medical schools in our nation. There are 42 addiction medicine fellowships now established and another 4 expected by year's end. In addition to being sponsored through medical schools, fellowships can also be sponsored by independent entities such as teaching hospitals. So there's room for even more. Can those of you at a school with an addiction medicine fellowship in this room, or an addiction medicine fellowship or planning one at your institution, please raise your hand? Thank you for bringing this work forward. We need you as clinical experts, as faculty, as teachers, as change agents, as persons who can come to meetings like this and work at every level of society to change the status quo. The addiction medicine is on track, and with your help, we expect to see the establishment of 125 addiction medicine fellowships by 2025. Some people say, well, that's an awful lot. You sure you need that many? I would remind you that sports medicine has 123. Medicine can do this. We can do this together. We must do it. It is why we are physicians. I would now like to introduce Dr. George Thibault, president of the Joshua Macy Jr. Foundation. Dr. Thibault is a thought and action leader in reinventing medical education. In addition, the Macy Foundation awarded a generous grant to the Addiction Medicine Foundation to engage medical schools in SAMHSA Region 3 states to explore the possibility of addiction medicine fellowships with a new model of education. The success of this outreach is now being extended to other states across the nation. Thank you, Dr. Thibault, for your work and your support.
Whoops, wrong way. There we go. Thank you, Kevin, and it's a pleasure to be here. I'm honored to be in this distinguished room with this distinguished group of people addressing one of the most important medical issues and medical education issues facing us. For the moment, I want to put this in context of broader changes in medical education that we at the Macy Foundation have been promoting for the last 8 or 9 years, and help see how these broader changes in the education of health professionals going forward fit into the goals of improving education for substance use disorders and addiction. We started with the thesis 8.5 years ago when I became president of the Macy Foundation, that the size, composition, and distribution of skills of the healthcare workforce will determine the success of healthcare reform, and therefore innovations in health professions education are needed to prepare the workforce for tomorrow. We needed to align health professions education with the changing needs of society and the changing delivery system. And of course, the issue of substance use disorders and addiction fit very much with that premise, aligning education with the needs of the public. We have chosen 6 areas of innovation, and I'm going to go through them very briefly. Each one of them could be a lecture in itself, and I'm not going to do that. But I'm going to make a comment about each and how it may be relevant to improving education for substance use disorders and addiction. First, and very important on our list, and it's probably been our principal area of focus, is interprofessional education. We now have an increasing body of evidence that healthcare delivered by highly functioning teams improves health outcomes, improves the efficiency of care, and importantly, improves patient satisfaction and professional satisfaction. Yet we historically have educated our health professionals separately, kept them apart until they're fully developed, fully licensed, fully accredited, and then are surprised when they don't work together as teams. They haven't learned the same language, they haven't learned respect for each other, they haven't learned how to work in teams, and they haven't learned what each of the health professions have to offer. So we've had a major initiative on changing that paradigm so that all health professionals will spend some part of their educational experience learning about, from, and with other health professionals. Now, the treatment of substance use disorders and addiction lends itself perfectly to this. In fact, one could say that cannot be done effectively without an interprofessional team combining the skills and insights that are brought by medicine, psychiatry, social work, nursing, public health. You can go down the list. This lends itself perfectly to an interprofessional approach. So by preparing all health professionals to work in teams, we will prepare them also for improved care of substance use disorders and addiction. Second, we need new models for clinical education. Our predominant models for clinical education still are oriented towards acute care, episodic care, hospital rotations of various lengths, rather than where most illness is today and will be in the future, and that is chronic disease, cared for largely outside of a hospital setting. So we need new models of clinical education that actually prepare the next generation of health professionals to deal with chronic illness in a longitudinal fashion, to work in teams to do that, to work in communities to do that, to work with patients and families over time, and also to work with mentors and teachers over time to acquire the skills to manage chronic disease. And you all know the substance use disorders and addiction are chronic diseases, and that one needs the skills and the understanding of learning medicine in that way to be able to treat chronic diseases. Third, we need new content to complement the biological sciences, which have been the underpinning for all of health professions education since the time of the Flexner Report in 1910. Those biological sciences are still absolutely necessary underpinning, but they're not sufficient today. We need to understand principles of population health, the social determinants of health, and other new skills like quality improvement, patient safety, pain control, that have previously not been a focus of our educational efforts. So introducing these new contents lend themselves again perfectly to understanding the full spectrum of substance use disorders and addiction. We need new educational models based on competency rather than time, and I think you're going to hear more about that from a later talk. I'm not going to emphasize that too much, but rather than just this certifying the adequacy of our education by time and place, to actually develop the tools to assess competency in the various skills that we want our health professionals to have, including understanding substance use disorders and addiction. We need to use new educational technologies, such as simulation, online learning, that will both facilitate the efficiency of our educational process, will facilitate the interprofessional approach to it, and will also enable us to teach at a distance, particularly thinking about the needs to teach and to deliver care in widely distributed parts of our country, particularly rural and underserved areas, which are particularly susceptible to substance use disorders and addiction. And finally, we need to pay more attention to develop the faculty to teach new content, to teach in new ways, to teach interprofessionally. Since our faculty all have been taught in the old way, we can't expect our learners to learn new skills, new attitudes, new approaches if the faculty don't know them, and we've paid too little attention to that. So if we are going to develop new programs, which we must, to treat substance use disorders and addiction and understand them, we're going to have to bring our faculty along, because by and large, they weren't taught those things when they were learners. Now, to do all of those things, we're also going to need to bring about a culture change in our educational institutions, in our healthcare delivery. We need to break down the professional silos that have separated the disciplines within medicine, for instance. Medicine and psychiatry, for instance, is a good example. And even more importantly, the silos across the professions, medicine, nursing, pharmacy, so that we really do get a true team approach, not only to education, but to the delivery of care. We need to develop closer ties between education and the healthcare delivery system that often run in parallel but don't talk to each other, so that the educational process is informed by the needs and changes in the delivery system. And the delivery system, as it reforms, incorporates the educational mission, so our learners are learning in the settings that are most attuned to dealing with today's and tomorrow's problems. And finally, we need, in all aspects of our education and delivery system, to be much more outward focused, much more focused on the needs of the patient and community, which should drive our educational process and drive our delivery system, so that as new problems emerge in the patient population, the education system and the delivery system are responsive to those. So there's a constant feedback loop. Now, I want to cite one example that change is taking place. An article published just last month in Academic Medicine, Developing Core Competencies for the Prevention and Management of Prescription Drug Misuse, a medical education collaboration in Massachusetts. The 4 medical schools in Massachusetts, the UMass, Boston University, Tufts, and Harvard, in an unprecedented way, I can say, because that's where I spent a good part of my career, have gotten together and developed together across 4 medical schools a curriculum for dealing with substance use disorders. This is a breaking down of silos across medical schools, a breaking down of silos between medicine and public health, since the leaders of public health were involved in this initiative, and also a breaking down of silos because this calls for an interprofessional approach. It's identified 10 competencies, I think familiar with those who are working in this area, focusing on prevention, focusing on secondary prevention, that is identifying subjects at risk, patients at risk because of misuse before addiction, and then identifying the competencies to treat addiction as a chronic disease. So this is a sign that progress can be made if we focus attention on it, and if we look broadly across the needs of reforming health professions education to meet the needs of the public, we will better address the needs of those patients with substance use disorders and addiction. So thank you for the honor of speaking to you, and I congratulate you all on this important work.
Thank you very much, George. See if I can advance this. Yes. I'm Dave Stern from the University of Tennessee. I'm the executive dean there and the vice chancellor for health affairs. I can say before I moved to Tennessee, I had the New Yorker or the Yankees view of Tennessee, which is, well, you can look pretty far, but you don't see Tennessee. You kind of look right to the Pacific. Tennessee is a state that actually has 2 time zones on the one hand, but more importantly, it has very diverse populations, from the Appalachian population in the eastern part of the state towards Knoxville. We all know what happens in Nashville. There's lots of country music. And there's a large underserved African-American population in Memphis. And if you consider that diversity, one thing that's a common denominator is, of course, the problem that you study, the problem of substance use disorders. The other kind of diversity there is there's rural and there are urban populations. And as was just stated, the rural populations really have a very severe problem with regard to substance use disorders. The basic hypothesis of my talk actually comes from something that was embedded in one of George Koob's earliest slides, where if you looked at it, you saw that if you put together alcoholism, substance use disorders, be it prescription drugs or illicit drugs, it's actually a much bigger problem than even the cancer problem. And what I'd like to suggest to you is if you consider the cancer centers at the major institutions or your institutions, the approach to cancer is clinically multidisciplinary, involving teams of people looking at the issue. From the standpoint of research, it's research that cuts across clinical and basic science to put together the elements that have to go with forming targeted therapies and finding the patients that can benefit most from those targeted therapies. And educationally, it spans everything from screening programs in the community to training people in community-oriented approaches as well as basic science. And what I'd like to suggest to you is that those of you who represent academic medical centers, that's what we can contribute to this field. We can contribute a multidisciplinary, inclusive approach that really embraces the population that in the end we would like to impact. So what I'm going to introduce to you is our Center for Addiction Science at the University of Tennessee. This first slide is Kevin Kuhn's slide of how the Addiction Medicine Fellowship, and I certainly agree, fits in an integral way into this. But our point is that an integrated approach to this is really, again, what the academic centers have to contribute. And if one is talking about each of the missions that we all are concerned with, clinical, again, multi and interdisciplinary services across all substances, and again, across the life cycle, because everyone in this room deals with everything from neonatal abstinence syndrome and infant mortality to problems that occur later in age. Educational, it's training the fellows, as we'll talk about, as cultural change agents, and I know that's a basic theme of this meeting. Research, multidimensional, and finally, leveraging each of these missions for the community outreach mission. If one takes a look at the multidisciplinary care, there are multiple modalities I've indicated on top, but the key is to get these different constituencies to really talk to each other and work together. One advantage I have as the executive dean is since they all work for me, when I ask them to get together, they do, but at least once. After that, one can't really always predict if they'll cooperate. But there's almost no one that couldn't be on this slide. If one takes the orthopedics that gives an elderly patient 60 days worth of an addictive narcotic, we know that they should be just as much involved in this. The other thing that comes up are care transitions. That's, again, something that in cancer, that's been the key. We call them navigators. We call them all different kind of things for coordinating care. We don't really have that in addiction medicine. In Tennessee, when a mother that's insured by TennCare that has a substance use disorder delivers, she's no longer insured. The baby is, but the mother isn't as soon as she delivers. So in other words, transitions in care from acute detoxification to more chronic, from inpatient to outpatient, from a pregnant mom to then becoming...
You have to talk into the microphone.
Oh, could you hear me? I hope so. So there's just multiple things in transitions of care that I think a multidisciplinary approach will have an important effect on. The same thing applies to the research in our field. And one of the things that we focused on is the neonatal abstinence syndrome, and in particular on genetic determinants of the neonatal abstinence syndrome, looking at the two distinct populations I mentioned to you, namely the Appalachian population, which has in our state about 200 cases of severe neonatal abstinence syndrome a year in the eastern part of the state, and in the western part of the state, the African American population in Memphis. We have a group that you can see of geneticists as well as pharmacologists and neuroscientists that are working on this on the one hand, but we need all the clinical folks as well, the maternal fetal medicine docs, the neonatologists, the addiction medicine specialists, behavioral health, and social work. I would say with regard to the wonderful work we heard about before from Dr. Skoob and Volkov, for sure the gene-environment interactions that were referred to and the relationship to genomics and personalized medicine is going to be the future, and it's for all of us to do that. And it's going to apply to everything from the vulnerability to substance use disorders, to the susceptibility to the complications, and the pace and the completeness of the recovery. And again, I'd suggest that an integrated approach that brings together people that can define the phenotypes and join them with people that can understand the genotypes, that's a way in which we'll be able to move the field forward. Finally, I'd like to talk about the Addiction Medicine Fellows. And we started an Addiction Medicine Fellowship program this July 1st, and we have 2 fellows that are in it. the emphasis is on interprofessional education. I didn't know Dr. Thibault was going to emphasize that in his remarks, but he doesn't remember for sure, but he was one of the people that trained me as a Harvard medical student many years ago. And so maybe I did learn something, Dr. Thibault. The addiction clinics that we run are really the perfect place for interdisciplinary education. Because although, as he pointed out, in the learning in the formalized sense, we often separate the students, in these kind of extracurricular activities in clinics such as that, there's no reason not to put together nursing, dentistry, medicine, pharmacy, and health professions, and we do. But perhaps the most important place where this plays out is in the health system, where there are lots of inpatient and outpatient facilities. And I'm very fortunate to have a wonderful partner that I've worked with for several years, Dr. Jeff Lieben, that's now going to come up and make some remarks with regard to the health system and the integration of these fellows and how he's trying to use this to change the culture in the institution. Jeff is the CEO of the Methodist University Hospital, which is the largest hospital in Memphis, and a senior vice president in Methodist Le Bonheur Healthcare. Jeff.
Thank you, Dr. Stern. Good morning. Dr. Thibault doesn't remember, but I actually was in the partner system for years, and he had some pointed comments for me too, which I can talk about another time. I want to thank you for allowing me to be here. Let me first describe what the Methodist Le Bonheur healthcare system is. This is the dominant healthcare system for the greater Memphis area and Shelby County. We are the largest Medicaid provider in the state. We do 350,000 emergency room visits a year. At any time within Shelby County, for the 1.2 million people we serve, 45% of the adult patients, inpatients, are in a Methodist bed. We have a predominant, pretty much exclusive children's hospital called Le Bonheur Healthcare, Le Bonheur Hospital. And again, we are sort of the safety net hospital because we provide the largest amount of Medicaid in the state as well as the largest amount of free care, if you will. We also have an open medical staff. And the reason I mention that is because when these patients come into the hospital, an open medical staff provides some additional challenges because the bedside nurse traditionally, or any other provider, falls back to the doctor who takes care of that patient. So my encouragement to you is train the doctors of the future, but do not forget that in those immediate settings, it is the general population and medical community that most of the nurses, respiratory therapists, pharmacists, et cetera, will look towards for advice and counsel as they move forward. Our need, honestly, is more infrastructure. And with this fellowship, we are hoping that we can start to train our inpatient providers, doctors, nurses, pharmacists, et cetera, in better ways to deal with these patients. There is a void in our market in particular, and our hospital is very interesting. If you go 10 blocks in one direction, you could be at $1 million home. If you go 10 blocks in another direction, you're at the third poorest zip code in the United States. So we truly get both ends of this spectrum and both many types of abuse. So with the partnership with the University of Tennessee, we're looking forward to using these fellows to train and set a new bar and standard for the way we're going to deal with these problems. Thank you, Dr. Stein.
I'd like to just conclude by saying I think it's important in this field that we really define the metrics and talk about what will success look like. One of the things that I deal with in dealing with deans and hospital CEOs all the time, they want to know what are the metrics of what's going to work and what's not going to work. And I'd like to suggest to you that you have a number of very firm metrics, whether they're medical or economic, but they really make a difference. I haven't put numbers on these, but clearly in every setting one could. But there are multiple important impact measures with regard to the incidence and the prevalence of substance use disorders, the medical complications, the costs, which in our state are very often very much borne by TennCare, our Medicaid equivalent in Tennessee, the social consequences, and of course the iatrogenic harm. And I'd like to just suggest to you again, if you take the analogy of the cancer center at your institution, that multidisciplinary model with respect to care and research and transitions in care, That's the model I think that very productively could be applied here to a disease which is really of the same or even a larger scope. And I think in that way we'll have benefits to all stakeholders. So I thank you for your attention, and I think we want to now move on to the panel responders. And I'd like to welcome first Dr. Sarah Wakeman, Director of Substance Use Disorder Initiatives from Mass General and Harvard Medical School.
She should speak from her speaker. Just turn it.
And apparently, Sarah, you should speak from where you're sitting. Okay, we look forward to your remarks.
Thank you. Good morning. It's an incredible honor to be here with all of you today. As we've heard this morning, it's no longer news that the opioid epidemic.
Sarah, can you turn your microphone on, please?
It's on,
It's on.
but I can bring it closer. How's that?
That's
There we go. I'll hold it. All right, let's try that again. Good morning. It's an incredible honor to be here with all of you today. It's no longer news that the opioid epidemic is a public health crisis. As we heard, by the end of today, another 78 Americans will die from an opioid overdose. Since 2000, 500,000 lives have been lost to the opioid crisis alone, which puts the carnage really on par with HIV and the number of American lives lost to the HIV epidemic. Substance use, including all addictive drugs, not just opioids, is truly the epidemic of our times. Yet, unlike the early years of other epidemics, such as HIV, when we needed to wait for science to catch up and for new treatments to be discovered, as we heard this morning, we already know what works for addiction. We heard about the incredible breadth and depth of science and the understanding about both the disease and the treatments. And that fact is almost as devastating as the deaths themselves, because truly no one should ever die from an opioid overdose. We have an effective antidote with naloxone. We have proven public health strategies to keep people who are at risk safe. And most importantly, as we've heard, we have effective treatment that can transition what was once a fatal illness into a chronic disease that can be successfully managed, just like hypertension or diabetes. When society and medicine have partnered to tackle other deadly diseases, we've had tremendous success. We've done so for infectious diseases, for stroke, heart disease, and cancer, and yet for addiction, the toll keeps rising. It's long past time for medicine and society to join together to meet this great need. There is a paradox, however, in addressing the addiction crisis. Unlike other diseases, as I mentioned, the issue with addiction is not the need for new discovery, nor is it for a continuation of a whack-a-mole approach where we chase one drug only to have the problem reappear with another substance. Rather, what is required is true ownership of the crisis and implementation of known strategies and treatments. For 100 years, as a country, we've chosen to marginalize addiction as a social problem or a criminal justice issue. And thankfully, we're now hearing our leaders say that we can't incarcerate our way out of a public health crisis, and nor can we punish or shame people into wanting to get well. But undoing that historic legacy requires educating not only our population, but also our policymakers and our healthcare providers about the nature of this complex brain disease. And it requires relentless advocacy to change policy and practice and serious and accountable involvement of the House of Medicine. As with HIV, we need physician specialists in addiction to increase training for all doctors to prevent, screen, diagnose, treat, and manage addiction. Addiction medicine fellowships offer the necessary training to create leaders, expert clinicians, faculty, and teachers. Addiction medicine physicians serve patients, but they also serve their colleagues. They serve as role models and mentors. They serve as a source for consultation and for guidance. Imagine for a moment if your loved one was diagnosed with a serious life-threatening cancer diagnosis. Wouldn't you want her to receive care from a board-certified oncologist? And wouldn't you want the cancer identified and prevented as soon as possible? The same option should exist for any patient or family member with the disease of addiction. Academic medicine and our health systems must also be involved. Formal education, training, research, and practice in this field are as important, if not more important, as in the over 100 other medical subspecialties. I thank ABMS for recognizing our new fields and ACGME for opening the pathway to accreditation. At Massachusetts General Hospital, I'm also a Harvard Medical School and Partners person, where I work as an internist and the medical director of our Substance Use Disorder Initiative. We will be seeking ACGME certification for our addiction medicine fellowship as soon as it becomes available next year. And as soon as the American Board of Preventative Medicine sponsors the first ABMS level addiction medicine certification, all of our addiction medicine physicians will become credentialed and certified. We can turn the tide on the addiction epidemic. We can create a future where no one has to die from this disease. Thanks for coming together today, and thanks so much for the opportunity to say a few words.
Thank you, Sarah, and special thanks to you and your colleagues for the startup of that fellowship at Mass General. Terrific. Our next speaker is Dr. Allison Whalen, the Chief Medical Officer at AAMC, which is the most heavily involved group with medical education in the United States.
Good morning and thank you. I've been the Chief Medical Education Officer at the AAMC since October 3rd. October 3rd, 3 weeks and 2 days. Before that, I spent the last 20 years as a faculty member in both the Departments of Medicine and Pediatrics at Washington University in St. Louis, and continued to do inpatient medicine attending, so firsthand experience with much of what has been talked about today. I want to congratulate the Addiction Medicine Foundation, ONDCP, and all the others who helped to organize this important discussion. Both are bringing us here today and for their work in raising the national consciousness about this incredibly important problem. So what is AAMC? We represent all 145 accredited U.S. medical schools, nearly 400 major teaching hospitals and health systems, including the 51 VA medical centers, and more than 80 academic societies. Although AAMC membership is institution-based, we really do our work through the individuals at those institutions, which includes 160,000 faculty members, 83,000 medical students, and 115,000 resident physicians. It's an incredibly exciting time for me to have joined the AAMC because it's a time of both change and challenge in medicine. Rapid advances in clinical and biomedical knowledge are transforming patient care, and medical educators are exploring new approaches to teaching and assessment to ensure that our future physicians are equipped to adapt as medicine advances and healthcare changes. An important paradigm shift in medical education is a major emphasis on the mastery of broad competencies, communication skills, and interprofessional teamwork that Dr. Thibault talked about, and you'll hear more about these from Dr. Hombo later today. These serve as a foundation for a physician in any discipline to provide high-quality work in any circumstance. And it's within this framework and the framework of accreditation that medical education programs design their curricula. So necessarily they vary from institution to institution. So every medical school does include content on substance use disorder in both required and elective courses, in both didactic and clinical work. It's integrated and taught in different ways in each medical school. Another thing that's important to recognize that I think has been mentioned here is the continuum of education. Medical school is 4 years. In a few schools, it's been shortened to 3+. Formal residency training is 3 to 6 to 7 to 8 years. And the vast majority of time that our physicians are in practice is when they're in the continuing education field. I'm a mid-career physician, and of the 3 approved FDA drugs, only 1 was approved at the time that I was finishing my formal training. So the imperative to figure out a way to really reach those physicians who are in the trenches, who are doing the work every day, as others have mentioned, is critically important. And I think the CE world is an area that all of us need to continue to expand in. So we think about our role in working with our academic health centers. The AAMC's role is primarily as convener and a forum for our members to share their best practices and learn from one another. We offer a variety of resources to assist our members in that work, webinars, and as you heard last year, my colleague described MedEd Portal. It's a web-based open access repository of peer-reviewed teaching and learning modules that we maintain. We've seen major efforts by our members in expanding their content in addiction medicine, and MedEd Portal is a natural resource to find classroom-tested materials. We specifically welcome the opportunity to work with those in this room to build and highlight a more robust collection of submissions focused on addiction medicine, and to utilize your expertise as potential contributors, reviewers, or even as an associate editor for this collection. As with any public health crisis, challenges in prevention, identification, and treatment of addiction have a number of drivers which all of you have talked about already today. And many of them extend beyond what education alone can address. So I really appreciate that others have highlighted that we need to continue to work on the science of addiction, which will better inform the care we provide. And as was said earlier by Dr. Koob, we need to learn about the most effective strategies to actually integrate those lessons into practice. I'm not going to test everyone whether they knew the 3 drugs that can be used in alcohol treatment, but as you know, they're highly underutilized. We need to figure out how to really make the change happen. And importantly, we can't overlook the deeply rooted societal and systemic factors that go far beyond what medicine and medical training can overcome alone. The treatment desert that was mentioned is not something that academic health centers can help with, and so the broad approach is critical. But medical schools and teaching hospitals are committed to doing our part to address these challenges in partnership with all the esteemed individuals in this room and the broader stakeholder community. Thank you again for the invitation, and I look forward to the discussion today.
Thank you for your remarks. I'd like to move on to Dr. Mary Lee Lay, Senior Vice President for Medical Accreditation from the ACGME.
Good morning, everyone, and thanks for the honor of joining this group. I'd like to tell you about the Accreditation Council for Graduate Medical Education, which is a private, not-for-profit organization that sets standards for U.S. graduate medical education programs and institutions. Accreditation decisions are based on compliance with the standards, and it provides assurance that a sponsoring institution or program meets the quality standards for which it prepares its graduates, with our main goal of preparing physicians for the future who can provide good patient care. We currently accredit close to 10,000 programs in the United States, and this includes almost 129,000 residents and fellows on duty. There are actually 3 sets of requirements that each specialty or subspecialty has to adhere to, and that includes the sponsoring institution requirements, the common program requirements, which all the programs have to adhere to, and the specialty and subspecialty specific requirements.
They want you to use another microphone.
It's not working. Is this better?
Closer.
I should hold it to my
A
mouth.
little
just
closer.
like you are.
Closer, ma'am.
Okay. Sorry about that. So each of these specialty or subspecialty is actually reviewed by a review committee that's comprised of volunteer specialty expert physicians or their peers. We recently added public members to these review committees. There's always a resident member, meaning a trainee, as a member of this committee, and it's run by staff at the ACGME. There's a very specific process for applying to become a new specialty or subspecialty, and this follows approval of that particular subspecialty by the member board of the American Board of Medical Specialties. Following this, a letter of intent is sent to the CEO of the ACGME, and that application is then reviewed by the board of directors, and if approved, an ad hoc committee is convened to review the application, following policies and procedures. And there's 8 major components that application has to cover. Once approved, program requirements are written in cooperation with the subspecialty experts and pertinent review committee representatives. The fellowship for the subspecialty of addiction medicine was approved by the ACGME Board of Directors on June 11, 2016, so just very recently. The fellowship in addiction medicine approval for accreditation is actually unique. And since everyone this morning seems to be using cardiology as an example, I'll use the same specialty. So for example, if you wanted to become an adult cardiologist, you actually have to complete internal medicine residency training, or if you wanted to be a pediatric endocrinologist, you have to complete pediatrics training, or if you wanted to do pediatric surgery, you have to complete general surgery training. So if you completed neurology training, for example, you can't just go and undergo cardiology fellowship training. So addiction medicine approval for accreditation is unique in that sense, in that anyone who has completed successfully specialty training can apply for a fellowship in addiction medicine. And we approved it in that way with a specific intention, knowing that addiction medicine is an important component of any practice, whether in internal medicine, family medicine, pediatrics, anesthesiology, emergency medicine, neurosurgery, or general surgery. Therefore, having addiction medicine specialists in any specialty would increase awareness of this wide-reaching problem related to addiction that would result in better care in this often neglected population. The process of putting together program requirements generally takes the most time, takes a year, pretty much. However, because of the much appreciated preparation and hard work by the members of the Addiction Medicine Fellowship Directors Association, this process has probably been cut in half at least. So right now, what we're doing is that the staff at the ACGME is reviewing the program requirements that have already been put together by the association. And once that is finalized, we'll bring representatives from the review committees and the addiction medicines community to review those requirements. And when finalized, that will be posted on our website for a 45-day review and comment period. The end product will be then sent to the Committee on Requirements, which is a subcommittee of the ACGME Board of Directors. They will review and discuss and present their findings and decision to the Executive Committee and the full board before it's implemented. Just a very quick word about the what the components are of the program requirements. There's a big introductory section which describes the residency and fellowship, a description of the subspecialty, its purpose, prior certification required, and the duration of training. Then there's 6 general sections, which comprises probably about 30-some pages. It addresses, the first component addresses the sponsoring institution and all the participating sites. Then there's a section on program personnel and resources, which covers the program requirement, program director requirements, faculty members, and other program personnel. Third section of fellow appointments. A fourth one, which comprises the educational program, including the competencies for the subspecialty. Then the very important component of evaluation, and that's not just evaluation of the fellows, but the fellows get to evaluate the faculty, and the faculty and the fellows get to evaluate the program. Last but not least, the 6th section deals with fellow duty hours in the learning and working environment, professionalism, and the recently added section of personal responsibility, including wellness and patient safety. Thank you.
Thank you, Mary, and thank you for your encouragement and collaboration between the leadership of ACGME and the addiction medicine community for the last 5 years. When we teach competencies, they have to be evaluated. There are several ways to do that. One is through examination. Our next speaker is Dr. Donald Melnick, who's the president of the National Board of Medical Examiners.
Good morning. The NBME is a 100-plus-year-old organization, a nonprofit rooted and focused on the assessment of physicians and other healthcare professionals for the knowledge and skills that support high-quality and effective patient care. We're best known as the developer and co-owner of the United States Medical Licensing Examination, USMLE, used in by all licensing authorities in the United States for the initial license of MDs, including all internationally qualified doctors. We also provide extensive assessment tools for use in undergraduate and graduate medical education, self-assessments for students, and assessments for other medical professionals, as well as other healthcare professionals like veterinary medicine, physical therapy, clinical research, health and wellness coaching, and many, many others, both in the U.S. and internationally. We have co-administered the Addiction Medicine Certification Exam with the American Board of Addiction Medicine since its first exam in 1986, adding to the rigor of the credentialing process, and we hope we've helped the exam evolve and grow as this field has come of age. We want to congratulate all of you who have advanced the field and thereby advanced the prevention and treatment of substance abuse disorders. In particular, thanks to the young career physicians in the room. You are urgently needed to address the preventable and largely untreated substance use disorders through our medical schools, our healthcare systems, and in society at large. With the recognition of addiction medicine as a subspecialty of the ABMS Member Board in Preventive Medicine, our support relationship with the American Board of Addiction Medicine is coming to an end. However, we are eager to assist wherever we can to encourage the momentum of this new subspecialty, and we hope to work with the American Board of Preventive Medicine to provide continued support for certification assessment in addiction medicine. In addition to our support for the certification program, NBME has a history of engaging with substance abuse and addiction community activities for many years. During the 1980s, we worked with a task force funded by NIDA to create assessments for use in medical and other health profession schools. Unfortunately, at that time, interest and utilization in this field didn't result in adequate support for the ongoing cost of sustaining the program, and its availability ended in 1988 after testing only 300 students. In 2010, we were invited by ONDCP to work with others to identify ways to place greater emphasis on substance abuse and addictions in the USMLE program. While USMLE is primarily about providing a credential for physicians to obtain licensure, it has profound driving effects on both teaching and learning. Volunteers from NIDA, HHS, HRSA, SAMHSA, and the Indian Health Service reviewed USMLE item pools and prepared recommendations for improvement. The USMLE Management Committee endorsed their implementation in May 2011. Central to the recommendations was to shift the focus from acute issues related to substance abuse to substance abuse as a chronic disease. While I can't publicly disclose the exact numbers of items currently in these areas on USMLE, I can assure you that this process resulted in a substantial increase in examination content related to substance abuse and addiction. These items now appear on every form of the multiple choice components of Step 1, Step 2 CK, and Step 3, and in many patient management simulations in Step 3 and patient interaction simulations in Step 2 CS. USMLE standing test committees routinely receive item writing assignments each year relevant to substance abuse and addiction. In May, we engaged with the Association of American Medical Colleges and Dr. Stein from ONDCP to review how fully the U.S. licensing examination system is vetting the knowledge and skills of new physicians. We shared in more detail the information I've just outlined, and we asked for further assistance in identifying content experts to work with us in the development of test content for USMLE. We look forward to continuing our decades-long engagement with your community and to assure that substance use disorders gain the prominence they deserve in the preparation of physicians to meet the needs of patients and society. If anybody here today is interested in working with us to improve assessment in this field, please just drop me an email at dmelnick@nbme.org, and the email address is in the attendee list. Thank you very much.
Thank you, Dr. Melnick. I think as much as anyone, you've told us that we're all on the same page in the same room going in the same direction.
Just say, as a medical school dean, we respond to that. What's on the USMLE? I think that's going to have a big effect on the culture in the residency programs and the medical student programs. We'd like to move on to Dr. Yu Maidi, the Dean and Vice President of Clinical Affairs at Howard University College of Medicine.
Thank you. My microphone works. It is an honor to be here to represent Howard University College of Medicine and Howard University Hospital. We at Howard have had a strong commitment in our support and research of and interventions in addiction medicine. Back in 1997, we developed the Alcohol Research Center with funding from the NIAAA, which at the time its fundamental purpose was to stimulate, strengthen, and facilitate multidisciplinary research and collaboration that would lead to the reduction of alcohol morbidity and mortality among minority populations with emphasis on African Americans. We next developed other projects, such as in 1998 we developed a medical education model for the prevention and treatment of alcohol use disorder, an alcohol intervention in an inner city emergency room in 2003, and using implementation science for community-based expert delivery in older adults in 2015. Projects both funded by the NIAAA as well as NIDA. We furthered our efforts and formalized it a bit more by having an addiction medicine elective for our residency program in 2004, screening SBIRT medical residency programs. We introduced the residents to that in 2008. We then expanded into the SBIRT medical professional program in 2014, which brought in nursing and counseling psychology and extended to nursing students. And in the same year, 2014, we extended the program to our first-year medical students. We have approximately 265 residents and fellows, 475 medical students, and over 200 nursing and allied health professionals, most of who come from all parts of the United States and are predominantly from minority ethnic groups. I would consider this the beginning of a force multiplier in the making. Finally, we're proud to have progressed to our Addiction Medicine Fellowship Program, which will be housed in the Department of Community Health and Family Medicine and will be strongly supported by experienced and dedicated faculty within Howard University Hospital, College of Medicine, and within the university itself. Core and elective rotations will be available across the spectrum in community health and family medicine, psychiatry, pediatrics, OBGYN, pharmacology, and the School of Social Work. This fellowship will leverage Howard University's unique position in diverse and underserved populations, and particularly here in the District of Columbia, where we've seen that the statistics themselves are fairly high in substance use. So again, this was a great pleasure that we've progressed this far, and we look forward to progressing even further. Thank you all.
Your turn.
Our next speaker, who I know, so I'm very happy to introduce her. We visited her school in Virginia. It was a great visit. So Dean Jan Wilcox, the Dean of the Edward Via School of Osteopathic Medicine at Virginia campus.
Thank you. It's a pleasure to be here. VCOM is a private, nonprofit osteopathic medical school with a mission to create physicians for rural and underserved Appalachia. And if you visit us in Southwest Virginia, it is Appalachia there. We've graduated 1,800 physicians, and 66% of those have returned to southern Appalachian states. The issues of substance abuse and addiction in these areas is well documented, particularly the rural areas, as other speakers have mentioned. The Virginia College is the main campus for VCOM. We're affiliated with Virginia Tech. We also have branch campuses in Spartanburg, South Carolina, and Auburn, Alabama, associated with Auburn University. We're 3 campuses with 1 curriculum. We recruit from, train in, and hopefully return to these rural and underserved areas. We've created teaching hospitals, core teaching hospitals in rural and underserved areas. And we have core clinical faculty that is part of our true faculty that teach our students in these areas. We begin in the first year with, in ethics and professionalism, introducing the students to opioid prescribing and including the CDC guidelines. That introduces, at a very first level, 500 students across 3 campuses to this each year. In our clinical skills and standardized patient cases, we digitally archive and view 20,000 standardized patient student experiences per year. So we have an opportunity to really study this aspect and how students present with a patient. And also we're finding out some of the word that's gotten back to clinical preceptors, because we notice that upper level students, when they come back for standardized patients, particularly in the last year, absolutely will not prescribe pain medication regardless of the complaint. So we see an opportunity here not only to see what's going on in clinical training, determine what needs to be done, what needs to be handled as far as educating the students. We can also do faculty development in these rural sites as a result of what we find from this. Much of the charge of the National Board of Medical Examiners, osteopathic medical examiners, is to protect the public. We're able to initiate this process early on in the formulative process of a formulative being a physician. We, of course, have opioid addiction as part of the behavioral sciences in second year. We're integrating prescribing and substance abuse within core third-year curriculum. And we've always provided a fourth-year opportunity for an elective in addiction medicine since our first class went on rotations in 2006. Our goal is to establish an addiction medicine fellowship. However, we do find some struggles in finding a program director that is interested in developing this in a rural and underserved area. So we do have a little bit of chicken or the egg thing going on here, and I so appreciate everyone in the room that is working so hard to create a workforce for us to take into these areas of need. So I really want to acknowledge also Dr. Coons and Dr. Bennett, who visited all the medical schools in Virginia recently and brought so much information to us and sharing. And as a result of that, recently, all of the medical schools in Virginia have recently met, plan more collaboration to see how we can tackle these issues across the state of Virginia. So thank you very much for this opportunity.
Thank you for your remarks, Dean Wilcox. I will add that of our first 50 fellowship graduates, 4 of those are now directors of other fellowship programs. 3 were new programs they started, so help is on the way.
Our next speaker and last speaker, but certainly for sure not meant to be in that order, is a medical student, Kristen Johnson, President, the Student National Medical Association. We're delighted to have you here. Where are you? There you are. It's okay, sorry. Please, your turn, Kristen.
Thank you all for inviting me here on behalf of the SNMA as well as the Medical Students of America. I'd like to talk a little bit about what's been said as well as what's going on in addiction medicine education for medical students. So we get a lot of what has been said as far as preparing for step 1 and step 2, making sure that we understand what we would see if a patient was coming into the ED with some type of substance that we were unable to identify by urine, or seeing what a patient would look like if they were coming in withdrawing. But some of the problem is that once we learn that and we learn these skills, as students, first and second year, we're then thrust into the culture of medicine. The problem with that is that a lot of physicians, especially our attending physicians, don't necessarily have the experience with addiction medicine to be able to give us the sensitivities that we need. This is especially seen where hospitals that have underserved communities coming in, as patients are talked about as pill seeking rather than actually looked at as a full patient. So these things are extremely important to ensure that we're able to go forward and do these things in changing the way that we treat our patients, especially those who have addiction problems. When you look at addiction as a health issue or as a disease, rather than it just being something that we are kind of pillaging towards the end of, I think it changes the way we as students are able to really expand our skills and able to address as future physicians. As president of the SNMA, one of the things that I really wanted to work on this year was making sure that our students have the opportunity to understand all of the doors that are open to them in going into medicine. And so with that, a couple of things that we're specifically working on this year include a plenary session at our national conference that will address addiction medicine, but especially addiction medicine in underserved communities, as well as looking at bias in medical education and ways that we can, as students, start to learn to kind of unpack these biases before we become physicians, and ways that we can assist our medical schools through research that we're doing nationally at the moment in curriculum that actually targets bias and targets ways that we can teach our students to fully look at patients as a whole. I feel like if we are able to achieve these things in medical education, then we'll have medical students that are fully able to take on this task and to potentially enter these fellowships and become really socially conscious and culturally competent physicians who will also be clinically excellent in helping us deal with this issue. Thank you.
Thank you, Kristen, for those great remarks. There is a future here. Thank you.